welcome to this talk, which today will be on the realistic needs of the newborn, focusing on the premature baby. So, a theme I often mention is the unique individual circumstances. There's no general one-size-fits-all. It's safer in hospital or it's safer at home. It can be either or both or neither. So, looking at if a baby's born or babies, it could be twins or triplets, and the mother's wishes to birth at home, making it as safe as possible doesn't necessarily involve a lot of things, but it does involve an individual assessment because at some point you may need to transfer if things deviate from the norm or there's a realistic probability that the babies will require things that we do not have at home. Some homes will be well equipped with a good team of staff that are well trained and can manage all sorts of scenarios, including kind of expect the unexpected, like apnea, like bradycardia that we will talk about. So the first thing is the preparation. What do we have? Now, sometimes waters can break, a baby's coming suddenly, there is no preparation. We're just going to deal with it the best we can. In these situations, the Michel Odent words resonate very simply and clearly. All the baby needs is the mother, or the mother needs is the baby. Now, oxygen requirements are a possibility, but not a high probability unless babies are less than 32 weeks, but it can be any time. A term baby can have an oxygen requirement. How are we going to meet that? So first off, the observations, very simple, temperature, pulse, respiration. Before that, we will have done an APGAR, and we continue to assess what is in the APGAR is 5 things that get 0, 1, or 2 points. So you've got respiratory rate, cardiac rate, so the respiratory rate should be around 60. If it's excessively high persistently, that's a sign of a problem. Heart rate between 120 and 160 approximately, and it can deviate from that briefly. If it deviates from that persistently or excessively, that's probably a problem. Temperature, people focus on high temperatures being infection. Actually, low temperature can also be signs of infection. So it's important to have accurate assessment of the temperature. Generally, we're doing that axilla, under the armpit, and that is usually 0.2 degrees Celsius less than the core temperature. But anyway, we're looking for a temperature around 36.5. Could be a little bit less if we're taking measures to warm the room and the baby up, which is skin to skin, 37 degrees from the mother or the other parent. And the room environment, especially after a birth, is really good to warm it up. Not necessarily to have a hat on a baby, that interferes with the microbiome and other things, but we're just looking at temperature, pulse, respiration. It's not the volume, rather, not the rate. It's always quality over quantity of anything, in my view. So how is the breathing? Is there nasal flaring? Is the lips pink or blue? Is the chest working extra hard? If there were signs of respiratory distress, it would show in the nose, lips, chest, between the ribs, under the ribs, and the sternum, and also the tracheal tug here, sucking in. So if you've got signs like this, generally babies need transfer, they need oxygen therapy. It's possible sometimes to give assisted ventilation at home. So at a birth, a baby may or may not require some inflation breaths. That would be 5 breaths with a bag and mask or with the mouth, having sucked the nose and mouth of the baby first, or done some postural drainage, or both. So you've got a clear airway, giving some air with oxygen. We're breathing in 21%, we're breathing out about 18%. That's the difference in hospital. We can give 100% oxygen or 50%, or whatever we want to give. But at home, we're very much more restricted. So the realistic needs of a premature baby could include oxygen therapy, could include respiratory support. Before all of that, it's very clear observations that are ongoing. A baby can change anytime. So we've got temperature, pulse, respiration. I was mentioning the APGAR includes heart rate, respiratory rate, colour, tone, reflex. So if you've got a white, pale, cold, floppy baby, this baby really needs urgent support. It could be provided at home, but it certainly needs urgent and highly skilled interventions. The observations we continue to do at home following a home birth are to watch the breathing, see for any increased effort, but also there can be apnea. Now, apnea, in a way, is a pause between any two breaths. It could be 5 seconds. What if it's 10, 15, 20? When is it called apnea? So hospitals have generally observed babies and set their alarm monitors between 10 and 20 seconds, depending on the maturity of a baby. So an older baby could tolerate a greater apnea. A more premature baby cannot. Similarly, with bradycardia, they can have a little pause in their heartbeat because it's immature physiology for the baby. And when the baby is older, it can tolerate a little bit more, although it's less likely to have bradycardias. And in some ways, bradycardias would be a greater abnormality in an older, more mature baby than it is more relevant and reasonable in a more extreme premature baby. Extreme premature, let's say, is between 24 and 28, and then 28 to 32 is significant premature, I would say, and then 33, 34 can be relatively normal if you've got a good birth weight. It also depends if there was an event that caused the mother to get hospital treatment before the birth, including an injection of steroids. The steroids given to the mother help produce steroids in the baby's lung mechanism so that the lungs normally can be quite stuck together. They need surfactant. It's an oily substance produced by the body when a baby's mature. So premature baby doesn't have surfactant. Artificial surfactant was one way to give it to them, but that's very time limited. You give it every few hours. That used to be done many years ago. By giving the mother a steroid injection, the baby's likely to produce its own surfactant earlier, including the premature baby. So that's a brief mention about apnea. We need to observe an apnea, stimulate a baby so it takes a breath, and know how to respond if a baby does not. So I mentioned earlier about a bag and mask. It's a very simple mechanism. It's inexpensive, 5, 10, 15, 20 euros or pounds or dollars. And it needs to fit snugly. It's quite good to have a C grip around the base of it onto the baby's mouth, nose and mouth, and an E grip around the baby's jaw. So you've got the C and E, and this is demonstrated in another video of mine. And the bag and mask, if it's 1 kilo baby, perhaps the volume would be appropriate at around 1 finger. 2 kilo baby, so if you've got a 1.5 baby, you're probably going to err on 1. If it's not enough, give 2, but maybe not complete compressions of the bag. 3 kilo and above baby could have 3, possibly even 4 for a 4 or bigger kilogram baby. 4 kilogram baby is approximately around 10 pounds. So most average weight term babies around 7 pounds, 3.5 kilos. So if you've got a pink, warm-toned baby, not a pale, cold, floppy baby, we're continuing at home, we're observing for oxygenation, we're looking at the lips, the nose, the chest. There's no increased effort. This baby's well, lots of skin to skin, naked. The whole body skin to skin with mother is going to give the warmth, but also it gives a feeling of security and hormone release that reduces the oxygen requirements. The next best thing is a sheepskin. So we did studies in intensive care and found that babies, for whatever reason, separated from the mother, they did better on a sheepskin than off a sheepskin, and they did better on the mother in kangaroo care than they did on a sheepskin or off of a sheepskin. So we've got kangaroo care, sheepskin, and the best we can replicate that. So with feeding, however helpful we are with breastfeeding, expressing a drop, maybe it's just a glistening, a shiny part of the milk, not even a drop, but then it becomes 0.1 of a ml and it will gradually increase. A lot of the research and my own experience with families over 35 years in neonatal intensive care units in various countries, high risk, low risk, medium, is that hands-on approach with breast for 24 hours is good, and then to use a pump frequently. The women who use pump every 3 hours during the 24-hour period, even at night time, especially at night time when prolactin is higher, would produce volumes of milk. And if they didn't express frequently, they were struggling to get the milk. Some jumped to drugs. Drugs have a negative side effect, unpredictable side effects, unintended consequences. For example, bromocriptine was given. It has a death rate of 1 in 5,000. And this is a common drug given in North America, Canada, even by lactation specialists. And you may want to weigh up the risks and benefits of a drug-based increase of milk, or a tactile oxytocin, feeling secure, taking care of the needs of the mother as well as the needs of the baby, because they are one unit. If we can really address emotional, everything, psychology, emotional, physical, so it's going to the bathroom, eating, drinking, feeling safe, feeling secure, realistic involvements, and talking about and listening to their perceptions and problems and how they're finding resources to manage any problems or potential problems. Wherever possible, sometimes it's useful to think about donor milk. If the woman giving birth is older, mid-40s, for example, she may be likely to produce less milk than a woman in her 20s. So do you know of a friend, a relative, a neighbour, another breastfeeding woman who would be happy to donate milk, and this woman happy to receive it? Some women have requirements about it being a non-smoker, or they may prefer somebody not to be vaccinated with various vaccines. And some want to know more things about the mother, but generally in childbirth and pregnancy, the women have their blood test screenings done in most countries to include and exclude rather the diseases like hepatitis, HIV, and other things, other viruses. So the milk is generally good, and in hospitals they're going to pasteurize donor milk. At home, you're not generally going to do that, although you may explore that possibility. Of course, pasteurizing destroys a lot of the benefits. And if a woman is feeding a 2-year-old, 3-year-old, 6-month-old, does it really matter? Yes and no. Is it better than formula milk? Definitely. So that's why somebody would have donor milk. They don't want to introduce something else into the digestive tract for the baby. On that theme, some people are recommending lanolin as a great nipple protector. It can be useful. Like anything, we need to be very cautious about what we're doing, because that's then introducing a kind of a food substance going through the baby's gut, and that can change things. Also, is the lanolin biological? Is it from grass that's been treated with chemicals? The cows have eaten this, or the sheep rather, and that's in their oil of their wool, and this is extracted as lanolin. So it does have good benefits, and research properties demonstrate this. We just need to be cautious whether to use it and where we're sourcing it from, and then how often to use it, if at all. I find simple things like fresh air, water, baby is latching well when we're not getting sore nipples, and this is the difference between, let's say, baby's sort of got a small mouth or got a big mouth. So watching the latch, having expert support with that. Expert support could be a friend, relative, neighbour, whoever is useful with that. So back to feeding, do we need a tube? If so, for a premature baby, yes, a 5, this is called a French gauge 5. It's very thin, very small and flexible, and it can run along the finger with the other end into the EBM, and baby can suck the finger without changing the muscle structure, the embouchure, the various muscles used for sucking and swallowing. A size 6 for a 3-kilo baby. So we're back to the relatively premature baby, 33, 4, 5 weeks, maybe 32 weeks. We'd have a 5-gauge tube, and it can run down the breast by the nipple. And mother can feed, putting the baby to the breast. The tube's there, the baby gets the reward, sensing, licking, smelling, tasting mother and mother's milk, if there is any, but getting the physical milk from the express breast milk. Throughout if a baby has a challenge, you're going to see it with feeding. They cannot breathe and feed at the same time when they have for example, a heart abnormality. So if there's anything else going on, maybe you've had scans, maybe you haven't had scans. And even if you've had scans, they're not foolproof. The estimated weight is not always accurate. And equally, if they're saying there's no anatomy or physiology problems, there can still be. So if a baby goes grey or a bit blue, particularly here, sweaty during feeding, that's a clear sign of cardiac abnormality, and the baby needs ultrasound of the heart. There's other tests to do. A simple test generally with all babies and premature, press for 5 seconds on the bone in the center. This is to see the central venous return. How many seconds does it take to come back? It should be less than 5 seconds. The quicker, the better. 2 or 3 seconds would be preferable. You can do it on the periphery. Hold for 5 seconds, take off. How long to pink up? Less than 5 seconds, 2 or 3 seconds would be ideal. I think we need to be prepared with a bag and mask all the time, 24 hours. That's why I say we need a team, because if you doze off, mother dozes off to sleep, you need a rest, need somebody else to cover, somebody needs to observe the baby. Without human observation, we can have an apnea alarm. You need to test it and test it and test it, frequently, at least every day. Set it to be sure it's on 10, not 20 seconds, if that's the requirement for this baby. And other monitoring that you could even possibly have at home are things to consider. So I'm sharing the screen. Yeah. If a baby's working hard, they need oxygen. If you've got it at home, it needs to be given through a valve that allows you to give a percentage of a litre, 0.1 of a litre or half a litre or whatever you want, of 100%. And you can have nasal cannula, you can even just wave it through a tube, or you could have a bag or mask type thing, a mask open by the baby's face. It doesn't have to be fixed on or anything like this. If you can then measure the oximetry saturation, fine. If you don't have that and you're just observing the baby, is the mucous membrane pink? This is crucial. So if it's yes and you want to carry on, you can. You've got your oxygen, but be mindful about the risks and benefits of being at home, the risks and benefits of being in hospital. Sometimes we transfer and we get the great help that we need. Sometimes we transfer and we get hostility or even infections in the hospital that are more problematic for a baby, even increasing mortality, morbidity unnecessarily. And even in a fantastic country like Netherlands, the Dutch found that the sinks in the hospital were holding terrible bacteria that killed several babies in the neonatal intensive care unit. So sometimes we're looking at transfer and saying, oh yeah, hospitals are safest. It's not always the safest, not just the Netherlands, Britain, all sorts of countries that are very developed and spend reasonably large amounts of GDP on their maternity healthcare system compared to some other backward countries. But then in some of the backward countries, I've worked in India, for example, people might be washing the nasogastric tubes, drying them in the sun, even giving them to another baby, washing their gloves, drying them in the sun. But sometimes what's in one family or one village could be safer still than going to a big city hospital where there's all sorts of tuberculosis and hepatitis, and if baby's getting treatments, how clean is the equipment that they're using. So sometimes poorly resourced countries find creative alternatives, ways to manage, and we're doing the same at home. You might be at home in a high resource country and still could be safer than in the neonatal intensive care. And equally, there are times the neonatal intensive care is a breath of fresh air, it's a relief. There's a lot of love, a lot of skill, a lot of equipment, a lot of funding, a lot of people who can care for a baby 24/7, which we cannot do without a proper team at home. So that's my fairly quick run through on the realistic needs for premature babies. Adding on elimination is important. So looking at what they're eating, working out the volumes. Of course, the volumes of a breastfed baby are vastly smaller than a bottle-fed baby that would start at 60 mils per kilo per 24 hours. So a 2-kilo baby would have 2 times 60, it's 120 mils over 24 hours. If you divide that by, say, 2 hourly feeds, 120, it's 24 mils every 2 hours. And it might be 3-hourly feeds. And they're things you'd gradually work to, and maybe even having nasogastric feeding. I mentioned elimination, so we want to see, are the bowels open? Is it passing urine? How often? We want 8 wet nappies, or passing urine 8 times in 24 hours by day 3. So at the beginning, it can be a bit dry. Look at the lips. If they're a little bit dry, even considered giving a bit of sterile water. Just, politically, some people say definitely not, but using a teat upsets the muscle structure. So using a syringe or a cup or a tube. You've got 3 options there to give 5 or 10 mils sterile water. The reason for possibly doing that small intervention is to prevent a greater intervention of going to hospital, having IV fluids for a dehydrated baby who may also get greater jaundice. So if you've got physiological jaundice, fine. If you've got some pathological jaundice, again, you may need blood tests and consider treatment in hospital. Ultraviolet light is the main treatment in hospital. It's very powerful, and they can give double lights. You can, of course, have great ultraviolet light skin exposure at home if you keep the baby as naked as possible, which is good for skin to skin and breastfeeding. And if you've got the temperature of the room nice and warm, have a wrap, 2 or 3 wraps rather than clothes. Unwrap the baby. Really good UV light to help synthesize or change the bilirubin that's built up in the body. If there's a possible infection, or there was trauma, or there's incompatibility of mother's blood group or some other complication, then baby needs a blood test and needs medical care in hospital. But if you're managing at home, if for some reason you're not able or willing to go to hospital, you manage it the best you can. UV light, fluids, and good breastfeeding, or donor milk, or combination of these things. I always welcome questions. Whatever I've omitted is interesting to go over another time. And in some ways, it's the basic needs of a baby. It's also the realistic needs of premature babies. The one thing I would say is team. We need a team, if that's the one takeaway. Thank you for listening.